بسم الله الرحمن الرحيم. سعيدة بالمشاركة في المؤتمر الثالث لقسم الأشعة التشخيصية طب بنها. شكر الجزيل لبروفيسور دكتور هشام الشيخ والسادة أعضاء هيئة التدريس قسم الأشعة طب بنها. My talk is about the role of H1 proton magnetic resonance spectroscopic imaging in evaluation of the spinal cord in multiple sclerosis patients. MS is an autoimmune disease that affects the brain spinal cord with a complex of relapsing and remitting course that includes inflammation, demyelination, remyelination, axonal loss, and gliosis, alternating or present at the same time. These changes occur in the lesions as well as in the normally appearing cord, the white matter, as well as the gray matter. The advanced MR techniques as the معلش هو في مشكلة في الكمبيوتر هنا؟ مفيش كونكشن بين الاتنين. انتوا زهقتوا آخر اليوم ولا ايه؟ محدش يقلب السلايد صح؟ بس كده. Advanced MR techniques as the MRS have been applied to improve our understanding about the pathophysiology of these changes. That technique provides information on the structural and biochemical changes occurring within and outside the macroscopic MS, namely in the normally appearing cord. So early diagnosis and accessing supplementary vital information is important to provide accurate therapy decisions and disease management. As you know, the most important neural metabolites are N-acetylaspartate, the creat, the choline, and the myoinositol. These metabolites can be used as biomarkers reflecting the state of neural viability and function in the form of N-acetylaspartate, tissue energy metabolism, the creat, cell membrane synthesis or breakdown as the choline, as well as the glial cell marker that is reflected by myoinositol. Additional metabolites are also important for the well-functioning neuronal tissue as the glutamine complex. But in the spinal cord, the most striking and is completely different than the normal brain is the presence of higher concentration of myoinositol on the MR spectrum, and so higher myoinositol creat ratio, while lower glutamate creat ratio. MRS of the spinal cord is a difficult technique. This is because of cardiac motion, respiratory movement, CSF pulsation, and the small size of the cord. This can be overcome by proper selection of the technique in the form of press technique, water suppression, fat suppression, shimming, cardiac and respiratory gating, in addition to proper selection of the pulse parameters, namely the echo time, TE. Usually we depend on using the short or the intermediate as we are targeting the short echo time neural metabolites in addition to the long echo time neural metabolites. What about the voxel localization and size? Voxel localization on the cord is very important. The voxel should be rectangular in shape, parallel to the long axis of the spinal cord, accurately applied on the lesion or on the normally appearing cord in order to ensure the spectral homogeneity and to avoid any voxel contamination with the CSF. Spectral quality and the metabolite profile depends on the level of acquisition. There are variations in the peak height and concentration among different regions of the spinal cord, but the most important is N-acetylaspartate is predominant, and on all levels, myoinositol is present in a higher peak height than on the normal brain. This is the normal MR spectrum of the spinal cord. Look firstly for the inner-stylus partite, which is predominant, followed by the create, followed by the choline, and there is also myoinstall peak at 3.6 parts per million. The MS usually affects the cord in the form of short segment myelopathy in the dorsal or the lateral aspect of the cord, or dorsolaterally. Accurate selection of the pulse sequences, mainly the proton density on axial and adjustment of the field of view, are all essential to pick up any abnormal high signal within the cord. Also, it can affect the anterior aspect of the cord, long segment myelopathy, like on this image, and here the cord is edematous with long segment affection, cervical and dorsally in the dorsal cord, and it can end in cord atrophy. What happens in MS? During active myelin breakdown, there is elevation of the membrane phospholipid reflected by the choline, together with the presence of some inflammatory products such as the lactate. Also, there is a change in inner-stylus partite create that indicates a disturbance in the cerebral tissue integrity and correlates with the clinical status of the patient. يعني أقدر أحدد البيشنت ده في which stage, relapsing, remitting, or progressive stage. Studies in the spinal cord of patients with MS showed decreased ratios of inner-stylus partite create, inner-stylus partite choline, and increased in both choline create and myoinstall create, both in lesions and in the normally appearing cord. Inner-stylus partite as a marker used accurately in MS, as it is reduced in all cases of MS, with more reduction in chronic than in acute cases, progressive than relapsing remitting, in the plaque lesions more in the normal cord, and in confluent than in the discrete lesions. Choline is the marker for the myelin breakdown, so it's used for early diagnosis of the demyelinating process. Its elevation and continuous elevation is seen in the progressive MS cases. Myoinstall, which is the striking metabolite, is significantly increases in MS cases. Its early detection reflects poor prognosis, and it is of high prognostic value for future relapse and disability. It's the most important marker in diagnosis together with the choline before significant reduction of inner-stylus partite. The persistent elevation of the myoinstall is indicative for gliosis, cord atrophy, and predicts poor outcome of the patient. With treatment, it is very important to evaluate the inner-stylus partite that should be normalized or recovered as regard the concentration and the peak height, and also the reduction in the peak height of myoinstall. All are indicative for good response to treatment and good prognosis. This is the MR spectrum of MS patient. Here, the choline and the myoinstall are found to be elevated even before any significant reduction of inner-stylus partite. Some MS patients with myelopathy symptoms, but the MR is completely free. The conventional MRI is free. This is considered to be a paradox. How to solve? We can solve this problem about is this cord is normal or diseased by MRS. Look for the inner-stylus partite create in the normally appearing cord, either the white matter or later the gray matter. Inner-stylus partite create in MS patients of the normal cord with variable clinical presentation helps to differentiate clinical stage of the disease, and inversely correlated with disability scores, especially in early stages. In addition, choline create, myoinstall create ratios are elevated in the normally appearing cord before lesions became detectable on conventional MRI. An increase in myoinstall level in the normal cord within 3 months of onset of the clinical isolated syndromes have been found to predict poor performance. So MRS can detect all these biochemical alterations in the normal cord adjacent or distant from the lesion, with significant reduction of N-acetylospartate and the elevation of choline peaks that can progress over time to a new lesion. Thus, MRS predicts newly detected lesion within the normally appearing cord, together with the increase in the myoinositol creat, choline creat, and reduction of N-acetyl creat, N-acetyl aspartate choline ratios. This table shows the metabolite alteration as regard their concentration and the peak height in a study done in Faculty of Medicine, Zagreb University, and also the alterations of the ratios relative to the normal ratios. دايما لازم يكون عندي charts of the normal metabolite ratios بcontrol patients matched as regard the age and gender. في كل patient ما اقدرش استخدم ال MS as a control for himself لان في changes في normally appearing white matter of the brain as well as normally appearing white matter of the cord. فلازم اختار matched control of the same age and gender. In acute MS, usually look for the elevation of choline and the myoinositol early before the reduction of N-acetyl aspartate. Early in the course of the disease, the creat is also reduced, which is the indication of reduction of the energetic process, followed by the chronic cases shows creat is elevated while N-acetyl aspartate should be recovered in relapsing remitting cases, while further reduction of N-acetyl aspartate indicates the patient is in the progressive course. The myoinositol also should be evaluated relative to the previous spectrum for any further increase. So any further increase of myoinositol can predict the occurrence of cord gliosis and cord atrophy. Some cases from our study, this is a case of acute MS with plaques on the conventional MRI, different sequences. The cord on T2 weighted image is completely normal. The field of view is adjusted, and we use the proton density sequence that detects multifocal areas of myelopathy within the cord in this patient. So MRS was done, single voxel press technique. Here, relative to the control in this image, okay, there is mild reduction of the N-acetyl aspartate together with reduction of creat, elevation of the choline, as well as elevation of the myoinositol relative to the control. So this patient is MS with a metabolite alteration in the normally appearing cord except the proton density. The patient should be evaluated in order to determine the clinical state, and here this MR spectrum should be considered as the reference spectrum for follow-up. This is a case of chronic relapsing MS, relapsing remitting case, no newly detected plaques on conventional MRI, but short segment myelopathy was detected in the cervical cord on T2 weighted images. The MR here spectrum is compared with the previous spectrum of the patient. We found the mild elevation of N-acetyl aspartate, mild reduction of N-acetyl aspartate. Here the creat is elevated because this case is chronic, but no further elevation of myoinositol relative to the previous one. So this case is relapsing remitting with no further elevation of choline or myoinositol. Also, MRS can detect what's called the occult MS, patients with no plaques on conventional MRI of the brain or even of the cord, but with myelopathy symptoms. We can diagnose MS in this patient, and we recommend follow-up, even conventionally and with MR spectrum for the development of plaques within 3 months later. This is a case of occult MS with myelopathy symptoms, but no plaques detected on the cervical cord or even the brain, but the metabolite alterations, early there is elevation of the creat choline and the mild peak of myoinositol. So we recommend follow-up for development of any plaques. teaching points, we can use the MRS with the following advantages in differentiating the acute from chronic plaques, determining the clinical subtype of the MS, relapsing, remitting, or progressive, evaluation of the occult disease, detection of the different pathological changes, and to predict the cord atrophy. Just 2 minutes. In addition to monitor the response to therapy. So we can state that MRS is an adjuvant tool to the conventional MRI because of its crucial role in evaluation of the biochemical changes that occur in the normally appearing cord as well as the spinal cord plaques in MS patients. These are some references from our study, and I would like to thank the team of our study, Professor Dr. Ahmed Raghib, Dr. Mohammed Zatoun, and Dr. Sarah Kamel from Zagazig University. Thank you so much, and good luck for all of you.
بنشكر الدكتورة فاتن على البرزنتيشن very nice presentation. وأي أسئلة ولا نخلي الأسئلة للآخر؟ طبعا أنا بشكر كلية طب بنها قسم الأشعة